Good morning, everyone. Thank you for joining me on today's episode of Blister Prevention Office Hours. Today we're going to be looking at blister treatment. Blister treatment is something that I find people either oversimplify or overcomplicate. So today I'm hoping to really distill it down into the basic factors, because I think it's possibly it's easier than you think. So let's make a start. All right, so the aims of treating blisters, I mean, if you think about if you have a patient come in with a blister, or even if you've got a blister yourself, what are you trying to achieve? It's fair to say one of the main things we want to do is prevent infection. That should go without saying. We want to stop the blister from getting worse, even though we have to pull our shoes back on and keep going, or our patient has to pull their shoes on and keep going. We want to reduce the pain, and we want to, in fact, give that blister some sort of healing momentum in spite of the ongoing activity, whether that's an athletic activity or an occupational activity, or just the fact that they have to put shoes on and the shoes press on the blister. So they're our aims. I coined the blister treatment equation some time ago because I noticed that some people were just focusing on the first aid component. So they were thinking about, let's put some antiseptic and a dressing on this, and therefore the job is done. And then wonder why their blister keeps hurting. So the antiseptic and the dressing is very important, but it's not job done, because the people that think that it's job done are the people that think that blisters are caused by rubbing, and blisters are not caused by rubbing, they're caused by shear. So when you put a dressing over the blister, you have eliminated the rubbing, but you have not eliminated the shear. Shear is still going on in the soft tissues underneath that dressing. And that's why the blister continues to hurt and get worse as you pull your shoes back on and keep going. So the first aid component, important for blister prevention, not that effective in doing the other things, as in stopping it from getting worse, actually making it get better and reducing the pain. The thing that provides those aspects of blister treatment is this component, the blister prevention component. So the blister prevention is basically the thing that minimizes the cause of the blister, which is shear. It could be taping, it could be an Engo patch, it could be a Spenco insole, it could be some sort of biomechanical alteration. These are the things that are going to actually reduce the magnitude of shear and bring about less pain, healing momentum, and stop that blister from getting worse. So if you think about this blister treatment equation, if we were to give all the blister preventions a number in terms of effect, let's say between 1 and 5, the bigger the number that you choose as your prevention, the bigger the meaningful blister treatment. So the more effective it will be at achieving those aims that we're looking for. And I say that because a lot of podiatrists and our patients, they're doing minimal here in terms of blister prevention. They're like, well, I've got a moisture wicking sock on, or I've, put some tape over it. It's not really, well, there's more that we can do, definitely, in terms of reducing the magnitude of the shear deformation and therefore bringing about less pain and healing momentum. So if we think about the blister process, there's basically 5 stages to a blister. From having no blister, we progress to a hot spot. If the blister causing forces keep going, then we have a blister with his roof intact. Then the roof can tear, and then it can de-roof. So let's have a look at what we need to implement across these stages for optimal blister treatment. So first aid, for starters, we need to put an antiseptic, or if you're in the US, we're talking antibiotic, on the blisters where the skin has been breached. So that's torn and de-roof blisters. These are the ones that need an antiseptic. Betadine, whatever your antiseptic of choice is. Still on first aid, we then need to put a dressing over it. So the antiseptic will kill any bugs that are there. The dressing will keep any new bugs out, and that's how we'll prevent the infection. You can put an island dressing on any of the blister stages. The blister dressing, so the island dressing, it just gives the blister roof or the wound base some level of protection, but also to keep it clean. So because we've got a blister roof, that skin that contributes to the blister roof has lost its underlying support. So it's quite fragile. So just giving a little bit of a cover will give it a little bit of protection, but mostly we're looking to keep the environment clean. Now, as an alternative to an island dressing, we've got hydrocolloids. Compeed is the most well-known example. Hydrocolloids should only be used on D-roof blisters. That is because they are an ulcer dressing, and the only one of these blisters that looks like an ulcer where this dressing is going to have full contact with the wound base is the D-roof blister. Hydrocolloids are adhesive. They're going to stick to the skin. Now, if that skin is weepy, it won't stick to that. So it's quite okay to put it on a completely raw or de-roofed blister. The weepiness from the blister base is going to mean that it won't stick, because what happens is the exudate and the fluids from the blister base will combine with hydrocolloid, form that kind of goo or gel, which is completely intended and what we're after. But if you put it onto a torn blister, you're putting it onto just dry skin, a little bit of wound, but mainly dry skin, depending on the size of the blister. And that an intact blister, as you go to tear or pull the hydrocolloid off, you are going to pull the whole blister roof off, whether you're doing that 24 hours later or 7 days later. So for that reason, hydrocolloids often make intact and torn blisters worse. It's an error that our patients are making, and our patients just need help understanding that. So in terms of first aid, it is antiseptic for torn and de-roofed. You can put an island dressing on any of these last 3 stages, or as an alternative to the island dressing on de-roofed, you can put hydrocolloids. So that's your first aid. And then we need to implement prevention. Prevention obviously is relevant to these first 2 stages. We want to stay in the blister-free zone, essentially. So implementing prevention right from the get-go is the ideal way to go. However, we've got one last chance for blister prevention, and that's to implement it at the hotspot stage. But prevention, as I mentioned, is so necessary if you want to achieve less pain, stop the blister from getting worse, and in fact help that blister heal in spite of activities having to continue. We need the prevention during the intact, torn and de-roof stages. And we don't just need any prevention or a minimal prevention, we need the best prevention we can find. So to just put all that on one slide, this is what it looks like. Meaningful blister treatment is the first aid plus the prevention. And this is how it applies to across the 5 stages. Make sense? If I just explain that a little bit fuller, this is how I explain blisters to people across the 5 stages. Ideally, we stay in the blister-free zone. To do this, we need to predict our blister locations. Now, blisters are more predictable than we think. The most predictable thing is we know where we're going to get them because we've had them there before. This is something that people tend to ignore to their detriment because it is the lowest hanging fruit. We've had a blister there before. We have some structural or anatomical predisposition, and I cannot believe that in the races that I go to, I always ask, have you had a blister here before? And just about always, they're like, yes, I have had a blister here before. and they don't really have a great prevention in place. So anyway, so we need to predict our blister location and use that intel to have the best prevention in place before we even start, or day in, day out. If we're talking about, you know, someone that's just blister prone in their everyday life or at their job. If we fail to do this and we actually feel a hot spot, great. The thing about the hotspot stage is it is subtle and brief. A lot of people wait too long. They wait until there's actual pain or there's a bit of a sting. The sting is the intraepidermal tear, which is the blister injury occurring. And it can take up to 2 hours for that blister to fill with fluid. So a lot of people think, oh, they take their shoe off. Oh, look, I've got to this blister, this hotspot at the right time. There's no blister here yet. They implement a prevention, and the next time they look, they've got a blister, and they think, well, that didn't work. Probably, well, sometimes it's literally the fact that they just didn't do it soon enough. A blister was on the way as soon as they felt that pain. So the hotspot stage is our last opportunity for blister prevention. You need to stop, drop, and implement the very best blister prevention you can find for this anatomical location. This entails carrying a great prevention with you and having it immediately available. So that's okay if you're a hiker, you're carrying a blister kit, but for the majority of other sports and activities, not usually applicable, which makes stage 1 even more important, predicting your blister locations, having the best prevention in place. If we don't do enough of the hotspot stage, what will happen is we will end up with a blister and his roof will start off intact. The best thing about this blister is the intact skin is keeping the germs out, and that's why we don't really need to put an antiseptic on this one. So the aim of the game here is to just give that fragile skin a little bit of protection with an island dressing, something non-adherent. We don't want to stick anything to that skin. So the non-adherent island within the tape, like the dressing, the rest of the dressing is adhesive, that will protect the fragile skin. And we have to implement prevention to stop this from getting worse. Remember, blisters aren't caused by rubbing. Yes, we've eliminated rubbing with the dressing. However, shear, which is the cause of blisters, is still happening underneath that dressing. So we need to implement a great prevention. And the prevention you implement is going to be 100% dependent on the anatomical location. If we don't do enough to stop the blister causing forces here, then the roof will end up tearing. The bad thing about this one is now it's open to infection. So now we need antiseptic and the island dressing plus our prevention, because it can get worse. We don't want it to get worse. We want to halt it in its tracks and in fact give it some sort of healing momentum. So that's the relevance of the prevention component. So for this one, it's island dressing after the antiseptic and prevention. If we don't do enough to stop the blister causing forces, then this blister will probably lose his roof entirely and become a de-roof blister. And we need antiseptic, obviously. We need a dressing, and that dressing can either be an island dressing or a hydrocolloid. Plus, we need our prevention, because even a de-roof blister can get worse. It can just erode into deeper tissue layers if we don't stop the blister causing shear well enough. I do have this little chart as a free download in our courses, our professional courses, including the free CPD course. So I'll show you where you can find that a little bit later. Let's have a quick look at some blister treatment misconceptions. I've just pulled out the biggest 3. The most common one that exists among our patients is that Compede or any hydrocolloid. I say Compede, I don't mean to pick on Compede, because it is the same for any hydrocolloid brand, including my own. Hydrocolloids are not the best blister treatment, okay, for all blisters. They're only a fabulous blister treatment for de-roof blisters. This one only. This is the only spot that hydrocolloids should be used. Hydrocolloids are only good for one kind of blister, de-roof blisters. They often make intact and torn blisters worse because the whole blister roof comes off with the plaster as it's removed. Misconception number 2 is that dressing choice is the most important thing. And I think podiatrists are probably in this camp more than our patients. Is dressing choice important? I find it's probably the least important thing. As long as you don't make the error of putting a hydrocolloid on an intact or torn blister, any dressing will do in terms of any island dressing. It is literally as easy as a Band-Aid. A non-adherent island with an adhesive surrounding. At its most simple, that is all we need. You can use Mepilex, you can use any sort of foam or cushioned kind of ulcer dressing. Yep, no problem. But at its most basic, all we need is an island dressing, or for hydrocolloids we can use, for deroot we can use the hydrocolloids. Any foam or padded dressing, or any dressing really, is not sufficient in terms of providing that blister prevention effect that we need to bring about less pain and healing momentum when we pull our shoes back on and keep going. So the dressing part really only comes into the first aid component of the blister treatment equation. It's not doing nearly enough for this. So if this is all you do and you put a real fancy Mepilex or whatever it happens to be on, don't think that, and that's all you do, don't think you're providing meaningful blister treatment, especially in an athletic or an occupational setting where this person has to be on their feet. Dressings help, but they're just first aid. If you want to stop a blister from getting worse and stop it from hurting, you need to reduce shear, just like you would to prevent the blister in the first place. Which makes you think, if we just got in at stage 1 where we had no blister, we could avoid all this changing of dressings and all that. The other thing that you should also get across to your patients is that it's not just, oh, my podiatrist put a really good dressing on, when that falls off, I'm good. No, they have to keep applying the dressing. Hydrocolloids can stay on for multiple days, but island dressings, I'm generally getting people to change that twice a day. In an athletic sense, it would be more often than that. If we really want to prevent infection, make sure things don't get macerated. So they have a responsibility to carry on that dressing and antiseptic. Misconception number 3 is you should never pop a blister. A bit like saying everyone should cut their toenails straight across. It kind of applies in some circumstances, but it is not it's not good advice across the board. Have a look at these blisters. There wouldn't be many of these that I wouldn't think I need to lance these, because if this person puts their shoes back on and keeps going, even if I implement a fabulous prevention strategy as well as a brilliant dressing, it's quite likely these blisters are going to spontaneously tear anyway. So sometimes it is good to actually lance a blister, do it in a controlled environment so that we can minimize the chance of infection. It's going to depend, though, on the circumstance of the activity. So let's say, you've got someone that works in an office, they can wear scuffs and their blister is on the back of their heel. Well, if the shoe isn't touching it and their activity during the day is irrelevant, you can leave that blister intact. I'm thinking more in terms of athletic situations and more weight-bearing blisters where there's an occupational setting where, let's say, someone works in in manufacturing or something where they've just got to be on their feet all day, farming, mining, all that kind of stuff. So sometimes it's preferable to lance a blister in a controlled environment to reduce infection risk. It is an entirely painless procedure. And I think podiatrists know this, but I don't think our patients know this. Sometimes they need to, particularly, I see a lot of ultramarathon runners. I'm not always there to pop their blisters or lance their blisters. So they need to make that judgment call themselves. and be set up with all the appropriate equipment. But it's certainly not a painful thing if you do it correctly. If you'd like to go into this aspect of blister treatment in more detail, about 2 years ago, we did a whole office hours presentation on this subject. So you can go back and have a look at that. I'll show you where to find the replays. And also, I do have a playlist on my YouTube channel of videos where I'm lancing blisters or other people are lancing blisters in different ways. So if you're a podiatrist and you just want to see how this goes, or if you happen to be looking at this video and you're not a podiatrist, but you want to know how to do it safely yourself, then this will kind of give you some information to make a start. All right, so let's have a look at specific blister sites and how treatment is going to play out. So these are all the areas that we can get blisters on our feet. How is first aid going to be different at all of these different blister locations? It's not going to be really any different. We're still going to need to put an antiseptic on all of them if they're torn or de-roofed, and we're still going to need a dressing on them. The only difference is going to be what size and shape of dressing you're going to put on it. And remember back to this. This is the first aid component of blister treatment, and it is relevant to all of those blister locations, those anatomical locations on your feet. But what about the prevention component? This one's going to be very different. And in fact, it's the most important thing to consider when we're implementing prevention as purely prevention or during treatment. The anatomical location of that blister is where you need to start. Too many people think, what's the best way to prevent blisters? Or what's the best prevention for running or hiking or tennis or whatever it happens to be? Or what's the best prevention in hot climates, in cold climates, in wet climates, humid, all the rest of it. They're how you nuance your final decision of blister treatment or in terms of the prevention component. The most important thing to think about and where to start is the blister location. So what's the best blister prevention for all of these locations? I couldn't possibly tell you. It's different for all of them. Now, if this is completely new to you, this fact of we've got to start with the blister location to know what is the best prevention, then please head over to our pro site. This is the podiatrist and anyone involved in blisters, foot blisters professionally. Have a look at the Learn tab and you'll find Blister Prevention University. So this is where I have gone through all of the anatomical locations for blisters and outlined what's the best prevention strategy for those locations. There is literally, this is the spot that you've got to start. Don't expect to find the best prevention for feet. It doesn't exist. Or the best prevention for your running patient load. It doesn't exist. You got to start at the blister location. Okay, let's get into some Q&A. We've got 5 minutes to go. Rebecca asks, treatment plans for different blister types, i.e. dressing selection. Here it is, Rebecca. Dressing selection, you can put an island dressing on intact, torn or de-roofed blisters. Alternatively, for de-roofed blisters, you can use a hydrocolloid. So there's your dressing selection. Antiseptic on any of them that have a torn blister roof. Does that answer the question? Treatment plans. Well, part of the treatment plan is the prevention component. This is the missing link. The bigger or the more effective the prevention you implement, the more meaningful the blister treatment. The first aid or the dressing selection is a minor component. It's important that we don't make the error of putting hydrocolloids on the wrong blister stage. But apart from that, it's the prevention that is the thing that's going to give us less pain and give that blister healing momentum in spite of having to put our shoes back on and keep going. Remember this that I talked about? We just went through the whole 5 stages of the blister process. If you would like to get a copy of this, head over to our pro site, click on free CPD. It's also in Blister Prevention University, but it's at least in our free CPD course, and you can get a download of this, and you can give it to your patients if you like. Question 2 from Tracy, what's the best prevention? As I said, Tracy, it really depends on the anatomical location. It's a question I just can't answer unless you say, what's the best blister prevention for X anatomical location? For example, last month it was a presentation all about Engo patches, and this was a slide from that presentation. So I went through all of the blister sites that I think Engo is a fabulous choice. And you'll notice, although Engo blister patches are my absolute favourite blister prevention, they are not applicable to all blister locations. So if you'd like to get back to me with a specific blister site, I'll be more than happy to answer. But I just need more information. Now, if you would like to see a replay of this Engo presentation, you can go to Learn and you'll find office hours in that drop down. This is where you see the replays of office hours. And again, in Learn, you'll also see the Blister Prevention University course, which is where we go through the whole thing. It's just the resource that we should have all been taught at university, which just literally wasn't the case. Teresa asks, the best way to prevent blisters when walking in rain and through water? Well, again, start with the blister location, and then we nuance it to the specifics of the activity. So if we think about through rain and water, what are some considerations here? Engo patches may dislodge. They're an adhesive patch that sticks on the shoe. For example, I recently coached a young lady through the Kokoda, and she was in her training, she was getting lots of blisters. She ended up getting through blister free, which was fabulous. Our blister prevention or our friction management strategy of choice was Engo patches. Even though the Engo patches could come unstuck because of the water component of the Kokoda, they actually stayed intact on the shoe the whole time, but they could have come loose. And so we needed a backup. I wouldn't ignore the Engo patches because they are far and away the best friction management strategy you can get, especially for an endurance activity like hiking the Kokoda. But we needed a backup. And so the best backup is a lubricant and maybe even armor skin socks. So she had both of those backups, and thankfully the Engo patches stayed in place the whole time. Something else to think about, moisture management strategies. If we're wearing a mesh upper sand shoe or running shoe, there's probably going to be a lot of water getting through, and so there's not going to be a moisture gradient for anything moisture wicking to actually function in terms of moisture wicking. So if you are sort of hinging everything on moisture wicking socks, they're probably not going to work in a wet environment. Most other things will work. You'd need to be a bit careful with gel toe protectors, because gel toe protectors can macerate the skin even at the best of times. But essentially, if that skin gets a bit waterlogged, let's say we've got a waterlogged toe skin and then we get a blister or a tear, you could not put gel toe protectors straight over that. It would only serve to macerate that skin further. So again, I would start with gel toe protectors right from the get-go. Number one is keeping the water off it, even though sweat is not evaporating. And then if we needed to ditch the gel toe protectors and then move on to something else, then that's what I would do. So again, see how I'm looking for what's the best prevention for this anatomical location. And I'll usually start with that, even if there's a chance that they will not be applicable later on down the track. But it's so important to have a backup and to understand why we need that backup and when to implement that backup. Again, if you could give me a specific anatomical location, Teresa, I could probably answer that in a bit more detail. But just looking through this list of preventions, taping might come unstuck. So again, that would be important to have a backup, although Fix-A-Mall wouldn't. That is quite water resistant. It'll stay on no matter whether it gets wet or not. Antiperspirants and astringents, they won't work, but they don't work anyway in terms of blister prevention. As far as the research shows us, we have very little research on blister strategies, but some of the research that we do have shows that antiperspirants and antiperspirants at least do not work, and nor do powders, particularly cornstarch and talc powders, the traditional powders. And astringents possibly don't work because really their mechanism, to my understanding, is they are a skin drying strategy. Well, as soon as the skin gets wet, that's out the window. Cushioned insoles will still work. Polytech pads will probably come off, just like how the Engo patches may come off. They might not. It depends on if you've got a really good adhesion to start with. Loose packed wool, I really don't know about that one. I would assume that will become way less effective if there's waterlogging. So if loose packed wool is your go-to, I would have a backup. So I hope that helps in some way, Teresa. Tinga asks, when patients break their own blisters then come in for help, is the best treatment dressing and allowing normal wound healing, then education? Well, yeah, I mean, we need the dressing and the antiseptic. So we need this, and we need to implement the prevention, and you need to educate your patient that we've got an open blister, be it torn or de-roofed. Educate them around the need for antiseptic, educate them around the options for dressings, and educate them around how frequently this dressing needs to be changed and the antiseptic reapplied, and monitoring for infection. You will also implement the prevention during the same consult. Very important. So you mentioned allowing normal wound healing. So we're looking for healing momentum in spite of having to pull our shoes back on and keep going. That is served by prevention. So for the specific anatomical location of this blister, understand what the best prevention is. From that, you can nuance it and have alternatives depending on the specifics of the activity or the climate. And you would be educating them on the relevance of that prevention. You'd also educate them on the fact that this blister location is now in your blister history. Blister history is the lowest hanging fruit when it comes to starting and finishing athletic events or just our daily life blister free. We need to predict the blister locations, and the lowest hanging fruit there is our blister history. So we need to have our best preventions in place right from the get-go. There's no need to wait until we get a blister. Just get the best prevention in place and take that blister out of the equation. It will just make the biggest difference to people. People don't really understand that this is possible. So this is the education that stands to really make the biggest impact on their active lifestyles. So if this is kind of news to you, if you're not quite used to thinking of blisters in this way, I can only highly recommend that you join Blister Prevention University. To get here, go over to our pro site, click on Learn, and in the drop down you'll see Blister Prevention University. It's a course that Doug Ritchie and I put together to try and get podiatrists and people involved in foot health and athletic foot care more educated about the real cause of blisters and what that means for the trickle-down effect in terms of blister treatment and blister prevention. So I hope that helps. A couple of minutes over. Thank you for joining me. Please, if you've got any questions, don't hesitate to get in touch, and I shall see you again sometime.